Support for UWTV is provided by the Boeing Employees Credit Union.
About 4 years ago, I was driving to Seattle on I-5 and traffic was snarled up, and I was in the fast lane going nowhere. The HOV lane was going by me about 55, 60, and a guy decided to move over to my lane and didn't realize we were stopped and tried to stop, but piled in the back of my truck. And took quite a hit, like a major whiplash, you know, head went to the steering wheel and back over the seat, and you know, basically just about knocked me out.
Clear.
I hang glide, and in order to hang glide, you have to lay prone with your hands out. You have to be able to hang on to these things, and you need your shoulders and your arms and your neck. You know, you need all this. And I do this from 5 to 7, 8 hours a day. By that, after the accident, I was pretty much done flying, and I tried to fly, but I couldn't be up there very long. And after just 1 hour, I'd be so numb in my hands, I couldn't even feel the bar. So I had to do something. I couldn't continue that way. Felt like my shoulders were both broken. I went to an orthopedic surgeon thinking I broke my shoulders somehow, and it turned out he's like, it's not your shoulders, it's your neck. So I went to a neck specialist, and they said, well, you have bulging disc, but slightly. It shouldn't cause any problems. And I actually went to a back specialist. They MRI'd me the whole bit, said, yeah, you're fine. You just need a couple shots in there, you're good. Finally, my wife Tina, she says, you know, look, let's get you up to U. So we went up there. I met Dr. Lee, and the difference was that he actually, he listened to me. He listened to the whole story. He knows I'm 52 years old. I know my body. He's like, okay, you obviously have a problem. Let's figure it out. So then he traced it back, and he took the same MRI and actually looked at it differently, and then found that the problem was where the nerves come out of my neck and feed my arms. After talking about it, I left for the surgery. It's a double fusion. I'm an active person. I want to be active.
Hello, welcome to Talk Medicine. My name is Michael Lee. I'm an orthopedic spine surgeon here at the University of Washington Medical Center. I specialize in the surgical treatment of degenerative and deformity conditions of the cervical, thoracic, and lumbar spine. Today, we're going to discuss degenerative conditions of the cervical spine and what sort of treatment options are available for the cervical spine. Degeneration of the cervical spine can often result in pain in the arms, numbness or tingling in the arms, possibly weakness in the arms. In worst case scenarios, it can often result in leg pain, leg dysfunction, and bowel and bladder dysfunction. Today we are joined by my patient and my friend, Larry Jorgenson. Larry, why don't you tell us a little bit about the symptoms that you were experiencing before you and I even met?
Well, I had shoulder pain and numbness in my hands and my arms. So that was the biggest thing. Is it felt like my shoulders were broken, and then my hands would go numb all the time. So. And
how long were you having pain and numbness for?
Well, I got in a car accident in April 2005, so it was pretty much after that forward till I had the surgery. Mm-hmm. And it just got worse and worse and worse, and to the point where I couldn't really function.
Now, you had a little bit of pain before the accident, but then after the accident, you really seem to have an increase in your pain. Is that correct?
Definitely. I had a little bit before, but I pretty much got over that, and I was good to go, pretty much back 100%. And then got slammed on the freeway. So.
Okay. Now, you're a pretty active person. Mm-hmm. Can you tell our audience a little bit about the things you like to do in your free time?
Well, I'm an active hang glider pilot. That's what I've been hang gliding for about 30 years, almost 30 years. And it's pretty much my family and my life. You know, we fly all the time. And I fly probably pretty close to 200 hours a year in a hang glider. And that's pretty much what determined the point where I couldn't do that anymore as much. So I just wanted to get back to that point. So
Now you're also being a little bit modest here. Now, if I recall correctly, you are the state record holder for longest hang gliding flight. Is that correct?
correct. I did that out of Chelan, Washington, into Idaho, about almost 200 miles.
200 miles. And how long did that flight take?
It took about 7 hours and 40 minutes.
Wow, that's
exactly.
a long time to be up in the air. So I don't know. I didn't know a whole lot about hang gliding before I met you. And from someone on the ground looking at someone up in the air, it actually looks pretty peaceful, pretty relaxing, not exertional. It doesn't look like you're expending a lot of energy, but that's not the case, is it?
No, it's not the case.
So.
It's we're working thermals and sometimes going up at 1,000, 1,500 feet a minute, and it's a lot of arm work. So.
And your arms are constantly out in front of you,
Kind of out
you're
in front
adjusting.
of you. And you got to hang on, because it's big stuff that'll tip you over and da-da-da. So it's a workout.
I bet it is. So you had pain particularly when you were holding onto that bar. And
That's
you
what
just
happened
fixed the
was,
flight.
yes, that's what happened was I had to hold onto that bar, and pretty soon I couldn't even feel my hands. And so, you know, you don't know if you're holding on tight or not, and, you know, just the aching in your shoulders and all that, so.
Okay. Outside of hang gliding, you were otherwise pretty functional. You still went to work and did most of your activities of daily life. It's just primarily this passion of yours that you couldn't do, and this really
Correct.
was affecting the quality of your life.
Yeah, I had, you know, headaches and the usual, you know, walk around with your kind of tipped, you know, even my secretary always told me, she goes, you walk in, sometimes you're tipped this way, sometimes you're tipped that way, trying to compensate, but I could get by. Driving was also tough because your arms are out here in front of you, so that would cause problems and stuff. But
Okay.
yes.
So Larry, you had seen other physicians, numerous other physicians for your condition before you actually saw me. How is it that you ended up in my clinic?
Well, I just wasn't getting any results. The bottom line is I still had bad arm pain and I was numbness, and I wasn't getting anywhere. I ended up in a spine surgeon that gave me the injections, all that, and then basically they just said there's nothing really they could do for me. And actually my wife Tina, she pushed pretty hard to try to get some results, and ended up at the U, and then I ended up with you there. So that's pretty much how it happened. And I was very excited when I got to the U and got with you, because of the fact that a lot of doctors just don't listen to you, and you sat there and listened to me and listened to me to what my pain was and what could cause that, and took the same MRI that other doctors had looked at, and you looked at the same one and found the problem. And so I was very excited at that point, and then it became a comfort level, and I felt comfortable that, you know, if you were able to do that, then you would be able to fix me. So.
What you had, Larry, was actually degenerative disc disease in the cervical spine. Now this is a model of the human spine. We can see this is the pelvis down here. The blue-colored vertebrae are the lumbar vertebrae. The green-colored vertebrae are the thoracic vertebrae in the chest. And the purple vertebrae up here are the cervical vertebrae, or the vertebrae in the neck. And this is really the area of interest in regards to you, Larry. So, as I said before, these purple vertebrae are the bones, the cervical bones, there's 7 of them, and the spaces in between are occupied by the intervertebral disc, these white spaces in between. These discs act as a site of motion, and they also act as shock absorbers for the cervical spine. Now, just for further anatomy, we can see that the nerve roots really come out the side of the spine here, and this is an example of a nerve root here, these yellow strings here. When we have degenerative disc disease, these discs can actually bulge or herniate out to the side, and they actually can impinge upon the space here. So these nerve roots come out of the space that we call the foramen. It's a little circular space where the tunnel where the nerve roots come out. And when we have degenerative disc disease, or bulging discs or herniated discs, they can actually herniate out into this area and push up against that nerve root. And that can cause pain. This is what's known as a pinched nerve root, which is a common term used by a lot of people. The medical term is actually radiculopathy, which is a lot of syllables. Radiculopathy can result in pain shooting down the arms. It can result in numbness, tingling. It can result in weakness down the arms. Another condition that we can see in the cervical spine is something called myelopathy, which is not pinching of the nerve roots, but pinching of the spinal cord directly. So this is another model of the cervical spine. It doesn't have all the nice nerve roots and muscles attached to it, but it allows me to demonstrate what myelopathy is. So again, these are the bones here, and these are the discs here. The foramen is this space right here where the pen is coming out of, and that's where the nerve roots will come out. Now where the spinal cord lives is actually right behind these vertebrae, and it lives actually in this canal here. So the spinal cord will live here, and it connect up to the brain up top here. Sometimes these degenerative disc disease can actually push back into the spinal canal and push against the spinal cord. And the medical term for that is myelopathy. That's a little bit more of an urgent condition. And the treatment options are usually more surgical for that than they are for radiculopathy. Now you, Larry, you had radiculopathy. So for radiculopathy, there's really 3 tiers of treatment. And for a lot of spine surgery, there's really 3 tiers of treatment. The first tier of treatment is the non-operative, non-interventional arm of treatment. And what that consists of is physical therapy and anti-inflammatory medication. A lot of patients will often ask me, well, how does physical therapy work? Well, as you know yourself, a lot of times we'll do traction in physical therapy. So what traction is literally just pulling up gently up on the head, and what that does is that actually opens up these spaces where the nerve roots come out. That can provide a little bit of decompression, and for mild cases of a pinched nerve root or radiculopathy, that can provide good symptomatic relief. Anti-inflammatory medications are also used, such as ibuprofen, Aleve, and what these do is they address the chemical irritation on these nerve roots. A lot of times we say pinched nerve roots, but really 2 processes are going on. One is the pinching of the nerve roots, and one is the chemical irritation or the inflammation that accompanies it. So the anti-inflammatory medication addresses the chemical irritation. So that's the non-operative, non-interventional treatment. When that really fails to provide long-lasting relief, we start thinking about the interventional, non-operative treatment, and that's an epidural steroid injection. Now, you had some epidural steroid injections.
I had 3 of them. Correct.
And did they provide you with any relief?
Immediately, they did. They actually put a numbing solution in there, and that worked really well. It lasted about an hour, but the long-term one didn't last.
So there's really 2 components of an epidural steroid injection. One is the numbing medication, which should give you instantaneous relief if we're in the right place, and the other is a steroid, which takes about 3 to 5 days to really kick in. So the fact that you got immediate relief was a good sign because it tells us that we're probably in the right area of what's causing your arm pain. The fact that it didn't last long is a little bit disappointing. And generally, we like to see our epidural steroid injections last a lot longer than a few days, really a lot longer than a few months. There's only a certain number that you can get in a year. And a lot of times these epidural steroid injections can be helpful in providing pain relief and hopefully preventing surgery. But when that fails to give you long-lasting relief, then we start thinking about the 3rd tier of treatment, which is interventional operative, which is surgery. So I'm going to show you a case here, a surgical case, and these are x-rays from a patient who had the same surgery as you did. So these are x-rays, AP and lateral, of the cervical spine. This is a lateral view, a sideways view, and this is the AP or anterior-posterior view of the cervical spine. Now we can see the vertebrae here. We can't see the discs on x-ray, but we can see the space they represent. And this is the canal back here. This is the front of the cervix, front of the patient, and this is the back of the patient. So on an MRI, you can see here, this patient has a herniated disc. So just to review the anatomy here, these are the cervical vertebrae. This is the 2nd one, 3rd, 4th, 5th, 6th, and 7th one. This large, bold line here is the spinal cord. And around that spinal cord, you see white behind the spinal cord and white in front of the spinal cord. That's called cerebrospinal fluid. The spine lives in a fluid-filled sac. And in situations where the spinal cord is being impinged or compressed, we'll see loss of that fluid like we see here at this level. We can see that we have nice fluid in front and fluid behind the spine here, but right here at the C5-6 disc space, we have a little bit of pinching of the cord there. Now this is a little bit different from the condition that you had in that you had more pinched nerve roots, but the procedure that we're going to review here is essentially the same. So this here is a lateral x-ray. This is an intraoperative x-ray where we have a marker here. This is a surgical tool actually on top of the spine. And the reason why we get this x-ray is to make sure that we do the correct level. Obviously, there are a lot of levels in the cervical spine. We want to make sure that we do the right one when we do the surgery. So this picture to your right, it's a little bit difficult to tell, and we do have video which will show it a little bit better. But these are pins actually going in here into the C5 vertebrae, which is right here. And this is a pin going to the C6 vertebrae. And this area here is the intervertebral disc. Now, that's a little cauterized, and that's not the normal appearance of the disc, but this is after we marked it, we took a picture. So this here is a picture of our discectomy, or us taking out the disc. Now here is actually the C5 vertebrae, and here's a C6 vertebrae. And with our surgical tools, we remove this disc space here, and we remove it to the point where it looks like this. Now what we're looking at here this white glistening area is actually the spinal cord. So you see some loose fronds of tissue here, and that's called the PLL, or the posterior longitudinal ligament. And we take that out as well to make sure that we get an adequate decompression of the spinal cord. Now, in your case, we actually went out to the side as well to do what we call a foraminotomy, where we made sure we had decompressed the foramen to make sure that those nerve roots were free. So this is the discectomy, and here we've adequately decompressed this, our neural tissue here. After that, we placed our bone graft into this inner space. You can see on this lateral x-ray here, this is the C5 body with a pin going into it. This is the C6 body with a pin going into it. And you can see this is our bone graft plug here. And we place this in between these two levels to promote a fusion. So essentially, what we're shooting for is to have these two levels fuse in one immobile segment. And this is an intraoperative picture where, again, you can see the pins coming from the front. This is the C5 body, this is the C6 body, and this is the interbody graft. After we place the graft, we then put a little plate on there to hold it in place. This is an X-ray, an anterior-posterior X-ray. You can see the plate going to the C5 and C6 level here. And this is an actual photograph of the same thing. And this little bone here is actually the bone graft that we placed in between the two vertebrae. And then these are our final X-rays, where you can see on the lateral X, where we have a plate going in from the a plate on top of the vertebrae with screws going in, and this is our interbody graft here, and this is the area of fusion. This is what we're looking to fuse. So Larry, now we're going to look at some video footage of the same patient. And just to orient ourselves, this is the head here, the foot is down there, this is the C5 level, this is the C6 level, and where that metal probe is going to be pushing is on the disc right there. See that spongy material? That's actually the disc space. So that's the disc space that we're actually going to remove. So here we are. This is actually a knife right here, and we cut into the disc space. And you can see that we cut from the outside in because we want to minimize any kind of risk to vital structures out to the side of the spine. And we can see that we're cutting into the disc space up towards the top of the disc here. And now we're cutting on the bottom portion of the disc there, making a little bit of a square or a rectangle. You see that?
Mm-hmm. Makes my neck hurt.
So here we are. Now we're actually taking out the disc material with our surgical tools. You can see we're actually just taking it out in piecemeal fashion, taking out all that disc material. And we use a variety of surgical instruments to get this done. One is with this instrument is called a pituitary rongeur, where we literally grab the disc and pull it out. We also use a variety of curettes and other instruments to help us perform a complete discectomy. So now here's after the discectomy. See, this white glistening area is actually the spinal cord here. And you can see we've got a complete discectomy. We've got a little bit of loose PLL still in the picture, but overall the spinal cord is largely decompressed. And as I stated before, for your case we would go out to the sides to make sure we decompress the foramen as well. Now what we're doing here is this is a high-speed burr. And we're actually burring the bone above and burring the bone below. What we're doing is we're preparing this bone for a bone graft placement so we can maximize our chances for a fusion. So, and then once we've prepared this inner body space, then we're ready to place our bone graft into the inner body space. And the goal is for that to fuse this vertebrae to that vertebrae.
When you remove that, do they want to come back together, and then you have to pry them back apart, or push them back apart, or to get your spacing?
Well, that's what these pins are for. These pins
I see.
actually, we put a retractor, and these pins act as a post so we can pull it apart and hold it apart. So Larry, you had a 2-level fusion on your neck because you had 2-level disc disease. Can you tell us a little bit about how you felt after the surgery and what your experience in the hospital was like with the surgery and immediately afterwards?
Well, I had the surgery, and it went well. I felt, I slept that night. Didn't really remember a lot, but the next morning I got up and I felt great. My arm pain was gone. It's post-surgery, so I'm a little weak, but I got up and they said, hey, you can walk if you want, and I got up and walked. And it was great to walk down the hall and not have arm pain and arm numbness and all that. And I felt great right away. It was just immediate relief. So.
I remember you and Tina, your wife, were very excited. I think she actually wrote on the dry erase board a new mileage and a new goal for you for your next hang gliding record. For
Right.
anticipating you would break your own record next season.
Right.
And of course, I said, hold on, we have to wait for this to heal. So with the fusion procedure, and the procedure is one part of it, but the fusion actually takes as long as 6 to 12 months to heal. And that's up to the body just to allow that fusion to occur. So sometimes it can take a little bit longer. There can be a slight delayed response. And that's actually what happened to you.
Correct.
But in the end, you fused just fine. But the point is, for 6 to 12 months after the procedure, you're still healing the bone. You're still healing the fusion. And during that time, I did place, initially after surgery, I did place you on some restrictions. Do you remember what those restrictions were?
Restrictions were no hang gliding and pretend like you're a piece of glass a little bit. It was hard because I felt great. I wanted to fly and all that, but I was pretty good about it. But I ended up just going to get my GA pilot license instead. So I was able to do that, and so it gave me time to heal. And yeah, so
great. Now you mentioned complete relief of the arm pain immediately after the surgery. What about neck pain? Did you notice any change in your neck pain?
Oh, it was immediately. It was great. At this point, you know, whenever I do things, sometimes I get a little bit of pain, but every day seems to be better. Every time I go out and do a big activity, I get less and less of it. So I think it's just over time, it's just gonna. To me, I feel like I'm going to get better and better and better. So
now that's a probably important point to differentiate. We had this conversation before the surgery and what our goals were with surgery. The goals are really to address the arm pain. You know, we as spine surgeons are very good at treating arm pain and leg pain for that matter, but we're not so good at treating neck pain and back pain. So what I remember telling you is that the goal of surgery is to get rid of your arm pain. Your neck pain may or may not go away, but you might still have some neck pain after the surgery. In my experience, a lot of patients do get a relief of their neck pain with the surgery, but that's not really the primary goal of doing the surgery. So you're kind of fortunate that you had a lot of resolution of the neck pain and complete relief of your arm pain.
Yep, no more headaches. It's great.
Fantastic. And afterwards, you were up in the air, not hang gliding, but you got your pilot's license. Is that correct?
Right. Correct.
So, what kind of activities are you doing now?
I'm back to pretty much full activity, riding bikes and motorcycles and hang gliders, flying airplanes. I do it all.
Fantastic.
I feel 100%.
Fantastic. When I told you that I recommended a fusion, you asked me, well, does that mean my neck is going to be stiff? Does it mean I'm not going to be able to move my neck? Can you tell us a little bit about your motion after the surgery and what it was like before the surgery and compare the two for us?
Well, definitely before the surgery, I had a sore neck, very, very sore neck. Range of motion was very limited. And after the surgery, right after surgery, it was sore and it took a while to heal. But at this point now, my range of motion is somewhat limited, but not bad. Looking up is probably the hardest thing. But you need to work on it and stretch it out because, again, you have fusion. So that means that other vertebrae are having to move farther. So you need to take your time and work it out. But I feel like I'm not limited. I can look and see everything I need to see.
It's an unusual sensation that the patients report because preoperatively they're having quite a bit of pain in their arms and there's this fear of inducing pain, so they have a guarded neck.
Right.
So after the surgery, after a fusion procedure when it's successful, a decompression and fusion procedure when it's successful, the patients are not having pain. They actually move their neck a little bit more than what they thought they were moving it before the surgery, which doesn't make any sense, but it's a perception the patient has, and I think you went through that as well.
Correct.
So,
yeah.
Now, you also asked me about cervical disc replacement. Do you remember that conversation?
That's what I wanted.
That's what you wanted. And because we had to do 2 levels, I told you that we couldn't. Currently, the cervical disc replacement surgery is not FDA approved to be done at 2 levels. But I did want to talk to you a little bit about it today. I have some cervical spine disc replacement models here. And this is a relatively new technology in the United States. We still don't have a lot of long-term data on how well these perform. The short-term data definitely shows that the relief of arm pain is just as good as a fusion procedure. Now, the reason why we do a cervical disc replacement is to preserve motion. So one of the trade-offs of your surgery is that we eliminate motion, but we will relieve your pain. With a cervical disc replacement, we try and preserve that motion. And the ultimate idea of a cervical disc replacement is that we prevent something called adjacent segment disease. Now, with a fusion, there's a risk for adjacent segment disease. Now, what is adjacent segment disease? Well, if I froze your elbow and I kept your elbow out locked, and you have to live the rest of your life like this with your elbow locked in this position, you could do it. After about 5 or 10 years, your shoulder might start to get a little bit sore, and your wrist might start to get a little bit sore because they're seeing higher stresses than they normally would. Well, the same thing is true in the cervical spine. In this model here, we have a cervical spine fusion. This blue spacer here to the side represents the bone. There's a plate here. Now, if I move this model back and forth, you can see there's going to be some motion here at the disc levels, but there's not much motion here. So because there's not much motion here where the fusion is, we see slightly higher stresses at the level above and slightly higher stresses at the level below. Now, many scientists and many people believe that this gives rise to adjacent segment disease, and sometimes people will need another operation at a level above or a level below later down the road. And the idea behind a cervical disc replacement is that without the fusion, without the elimination of motion, you take the tension off those adjacent segments. As of now, we're still waiting for the long-term data, and it really takes about 10 years or more to really study this. I wish I could have done it in you, because it is a procedure we do at the University of Washington Medical Center, but right now it's only approved to be done at one level.
Right.
So we did have this discussion, and it's just a matter of timing for you. Well, Larry, it's always good to see you. I want to thank you for taking the time to come down and be with us today. Thank you very much.
And I want to thank you.
And I'd also like to take an opportunity to thank our viewers at home. Thank you for sharing this time with us. My name is Michael Lee, and this has been another edition of Talk Medicine. Thank you.